where I said do yourself a favor and trace out the tubules just to make sure you know exactly what you're looking at, because based upon the way the artist draws the picture, it might confuse you, right? So if you're looking at this, we have the glomerulus right here, right? And then what's this? Bowman's capsule, right? And then immediately out of Bowman's capsule is the proximal tubule, right? And we go down the descending loop of Henle, the turn, and then up to the distal tubule, right? And where's all this stuff right here?
Cortex.
Cortex, right? And all this stuff down here?
Medulla.
Right? Okay, but if you look at that one, you just keep looking at the same one over and over again, right? And then you look at this one.
Yeah.
You see what I mean? Now, the proximal convoluted tubule goes this way. And so basically what I'm trying to do is avoid the trap of just looking at it, memorizing a picture, and saying the right side is a proximal convoluted tubule. That's not always the way it is. So just do yourself the favor and take a breath and trace it out to make sure that you don't get a simple answer wrong. Okay? Does that make sense? Right? And then you get something like this, right? Okay. And you got to trace it out. So we have the proximal convoluted tubule. You know that comes after. And then we go all the way down the thing, and then we come up here. Here's the distal tubule over here, and then into the collecting duct, right? So just take a minute and trace it out so that you, if I say, what is this thing? You don't just bite off on the wrong answer, okay? Speaking of what is this thing,
Glomerulus.
Glomerulus inside of Bowman's capsule, that's right. Okay? So glomerulus, these guys right here, right? What are these little yellow guys in the middle? Anybody remember? Nope, the little guys in the middle.
Cells.
Mesangial cells that expand and contract. The little octopus are what? Podocytes. Foot cells, that's right. And what are the little things that come off? Their little arms. Foot processes, right? Otherwise known as pedicels, right? Okay, good. Which one do you think is the efferent arteriole? What'd you say? The big one. This one, right? This one, right? And there's a lot of other things in here we haven't talked about yet. So what then is this little guy right here? The beginning of? The proximal convoluted tubule, right? And then what do you think this guy is? It's the distal convoluted tubule. Very good. Okay. What? What? That doesn't sound right. So here's what we're going to do today, you guys. I've been here long enough to notice a few anxious faces in the audience. It seems to be a little bit of an extra consternation about Mr. Wright's exam tomorrow. So what we are going to do is turn to page 180 on your slide deck, and we're going to do the urogenital anatomy, which is very easy, about 30 slides worth, and then we're going to get out of here so you guys can study, all right? Because I don't want renal physiology to be white noise. It's very important to me as a provider, and it's very important to you as a future provider. So we're going to talk about tomorrow after the exam when you're all happy because you've all gotten A's and crushed Mr. Wright's exam. Is that fair? Good, because that's what we're doing. All right? Then here's some for you from yesterday. Okay? Parenchyma, or parenchyma, if you put the emphasis on the wrong syllable. All right? So there you go. That's what parenchyma means. Versus stroma, versus the structural support cells, right? So that's why we're talking about the nephrons. The nephron mass is the functional tissue of the nephron, okay? So now we all have learned things today. Okay, this is where we're going to start today. I'll give you guys a second if you want to play along at home, assuming that you're not already on your notes from A&P Ii. Okay? It's not my first day. I know what's going on. It's all right. I understand. That's why I want to do the easy stuff today, because I want the hard stuff to be when you might be paying attention slightly more. I will appreciate that. So, urine elimination. Okay, and really what we're going to focus on today is we're not focusing on urogenital anatomy. I said that is incorrect. We're going to be looking at the ureters and the urethra, right? The genitals themselves, the penis is basically a conveyance in the renal system for urine to come out. All right, we're going to talk about the structures within the penis and the uterus at the end. That's block 7. Okay, so right now this is really simple stuff. All right, we're talking about tubes that convey pee out. And what is the bladder essentially? It is a bag of urine. That's what it does. Okay, so it's not that difficult with the anatomy. So, right, remember what the minor calyces are? Where do we find those? Right after the papilla, right? Right after the renal pyramids, the point of the pyramid is the papilla, and the urine just starts to drip down there from the I'm gonna go outside. I'll be right back. Minor calyx into the major calyx, right? Into the pelvis, down now into the ureter, and now into the bladder. From the bladder to the urethra, and then out into the toilet or wherever you so choose to urinate. All right. Peristalsis, urination is the urinary peristalsis is a thing. Everybody know what peristalsis is, right? Usually we think about peristalsis where? In the gut, right? The movement of that bolus of food along to the digestive tract. Urinary peristalsis also does occur. The reason why, does anybody here ever had a kidney stone before? No? Anybody ever seen a patient with a kidney stone?
You got one.
Lots of pain. And it's a pain that we refer to as colicky pain. Colicky pain is pain that comes in sharp waves and then goes away, versus constant, steady pain. The reason why urinary peristalsis is important to that patient is because it's what causes their pain. If you have a rock ripping its way through your ureter or your urethra, every time that urinary peristalsis tries to move the urine forward a little bit, it either blocks, it butts up against that rock, or it tears a little bit of that mucosa. So that's why they're in so much colicky pain. Okay, so urinary peristalsis is just the movement, right? It is still smooth muscle tissue in those ureters, in the bladder, and in the urethra, okay? So ureter itself, obliquely to the inferior and posterior aspect of the bladder. So it doesn't come straight down. It comes sort of back in this way, and that's physiologically, anatomically important because there's no true sphincter that prevents reflux from the bladder up to the ureters. So that oblique angle that it enters sort of acts as a physiologic sphincter. And as it fills with urine, it pulls it down more and sort of closes that gap off, okay? There is a pathological condition called ureteral reflux, basically, and that causes kidney problems in patients that have. You find that in kids sometimes with a lot of urinary tract infections. So it's an incompetent ureteral sphincter, so that urine is allowed to move back up towards the kidney, right? So layers, superficial to deep, again, so outside to inside. Adventitia, muscularis is the middle layer of almost all things we're going to talk about. It's the same thing with like the vessels. We talk about the gut. The middle layer is usually the muscular layer, okay, and that's what is responsible for that peristalsis. And then the mucosa. So one other word, well, actually, let me ask, does anybody know what transitional epithelium is? Huh? It's able to expand, right? And it's able to extend. The other name for transitional epithelium in this system is urothelium. So if you ever see the word urothelium, it means the same stuff. And essentially, it's stretchy. Because what has to happen as the bladder fills with urine? It's got to expand a little bit. Okay? Same thing. As the urine passes its way down the tubule of the ureter, it's got to expand a little bit. Otherwise, it would cause a lot of pain. Okay? And then goblet cells. We'll talk about those a lot when we get to the stomach. I usually think about them as having a goblet full of mucus. It's gross, but that's what they make is mucus. All right? And the mucus essentially lines and protects the mucosa. Because again, what is urine? A caustic waste product, right? So that mucosa is tender, right? And it is sensitive. So we need to have the mucosa covered in that protective mucus layer so that it doesn't hurt and doesn't create any kind of infection. Literally, so it also doesn't find a crack and infect that barrier and get in there and cause some sort of urinary tract infection. Okay? We talk about breakdown of that layer is a potential reason for a urinary tract infection. Okay? So I know you don't have this picture. I just think it shows it a little bit better. I mean, essentially, this is simple anatomy. They come out of the renal hilum here, the renal pelvis, and they meet down sort of towards the back angle of the bladder, okay? And again, that oblique angle, which is better highlighted right here, as that bladder, the literal weight and the gravity of that urine pulls it down, sort of closes that space off to prevent backflow, okay? Yes?
So maybe a little off topic, for that horseshoe kidney you talked about, will
Uh-huh.
they still have separate ureters or just a single?
It depends on where the fusion is, but usually they'll have separate ureters, yes. Yeah. Actually, I'll show you. Hold on a second. We're going to take a trip down memory lane. Hold on. Hey. This is real time. Let's see if I can find it. Stop whispering. I'm going to get to it fast enough. See, if you look at this guy, see, typically, even if they're fused at the bottom pole, they'll still have, and you see that actual physical anatomic specimen does have two separate ureters. So yeah, but if it's fused in the middle, it might just have a single one. But typically, still it fused at the top, bottom, anywhere else would have multiple. So, all right. That was worth it, you guys. All right, okay. I think. Okay. So again, just pulling down, and that vesical ureteral reflex. So vesical being having to do with the bladder, ureteral have to do with the ureters. Reflux going in the wrong direction. Again, as that happens, these patients are more prone to infection and a condition called hydronephrosis, where actually it starts to break out the renal pelvis and actually kill some of that renal parenchyma because fluid isn't supposed to flow that direction, right? So that physiologic sphincter right here is actually very, very important anatomically. Okay. So there you go. There's a picture of it. Just pulling down on the ureter. Okay. Bladder anatomy. It's just a bag of urine. Okay. And that is exactly what it does. It's when I would teach about bladder infection, right? It's container for that waste product. It's protected by the mucosa and it's cut off obliquely from urine going superiorly back into the kidney. And so that containerized waste product, if a patient just has a bladder infection, like a cystitis, infection urine, should they have any symptoms anywhere else, like a fever or back pain or anything else? They wouldn't, because that infected urine is just containerized in their bladder. Now, if they start to have other symptoms like a fever, chills, back pain, now we're thinking that maybe that infected urine has gone up into their kidneys, and that's a condition called pyelonephritis. So the physical function, the actual anatomic function of the bladder is quite important, because again, it's holding waste to be excreted. Okay. In immediately anterior and slightly superior in males, and then in females, it's anterior to the uterus, okay, slightly inferior, so it's a little bit down. And that reason, unfortunately, so there's the male bladder, right? Here's the prostate, and then we'll talk about the urethra as it goes through. Females, unfortunately, for you, if you get pregnant, your uterus with that heavy baby sits right on top of your bladder, and which is why you have to pee all the time. Okay. In the urinary bladder, the serosa is the outside top portion. Okay. The adventitia is the back and underside. All right. Adventitia is another layer, just like the renal capsule, that is continuous with the ureters, but on the inferior side, so distal, of course. So proximal at the kidneys, that renal capsule is continuous with the ureters. At the distal end of the ureter, the adventitia of the bladder is, yes.
So the adventitia and the serosa are those are two separate.
They're two distinct layers, but they're just coverings, right, of the tissue itself. Why does it have two layers? If that's what you're asking, I don't know the answer to that. Muscularis is the detrusor muscle, okay? Like I said, usually the middle layer. Detrusor contraction, like contraction of the muscularis, that's what helps move the urine down into the urethra in preparation for micturition or urination. Okay? Lamina propria is before the inside, right? The interior layer is the urothelium, the mucosa, just like in the ureters. Okay? The lamina propria is more of a supporting tissue. Like the bladder doesn't have any parenchyma, like we're using words now, right? It doesn't really have any functional tissue, so per se, it's just a container. All right, so this lamina propria is a lot of stroma tissue, just supportive connective tissue. This is what makes it nice and stretchy, though. Lots of elastic and collagen. Okay. The rugae are folds. If you've taken anatomy before, I assume you've talked about rugae in the stomach. There are rugae folds and wavy surface inside the bladder itself. Okay? And this trigony is literally just like a triangle-shaped area at the floor of the bladder, right where it meets the urethra. So it's kind of like the ureteral openings are here, and the urethral opening is here, right? So you can see ureteral openings right here, and then into the urethra. So it's just this triangle-shaped floor of the bladder. I don't know how well you can see the red, but so that's the trigony, okay? Trigony, detrusor, all involved in urinary continence, right? Have you ever heard of an overactive bladder before? Overactive bladder is a form of urinary incontinence. That is detrusor overactivity, meaning detrusor spasticity. And those patients usually will feel a sudden urge to go to the bathroom really quickly. Urethra, it's just the tube, okay? Two sphincters, anatomic sphincters. Maintain, again, for the maintenance of urinary continence. One is involuntary, one is voluntary. Okay? Internal urethral sphincter, smooth muscle, so that makes it involuntary, right? External urethral sphincter, skeletal muscle, which makes it voluntary. Okay? So two mechanisms to prevent leakage of urine, two additional mechanisms. Male urethra is longer, which is why males typically experience fewer urinary tract infections, because the primary route of a urinary tract infection is literal ascent of bacteria up through the urethra. So the physical length of the urethra in men as compared to a much shorter urethra in women is why predominantly UTI is a female problem. Not entirely, but predominantly. You guys will learn about that later. Sections from inside to out. So interior to exterior, prostatic, then membranous, then spongy urethra, okay? So the prostatic urethra goes through the prostate. Membranous urethra goes through the shaft of the penis, and the spongy urethra is the head of the penis, okay? Anybody see a reason why there might be urinary problems in older men based on the makeup of the urethra, of the sections of the urethra? Prostate problems, exactly, and that's what it is. The prostate is the problem. The urethra passes through the prostate. As the prostate begins to encroach on that prostatic urethra, men begin to experience urinary hesitancy and all of those older bladder symptoms of prostate problems. You've seen the commercials probably, right? Prostatic urethra also has openings from the prostatic ducts and the spermatic ducts, so a conveyance of semen and sperm as well. Okay? So, spongy urethra, prostatic urethra through the prostate, membranous portion, and then spongy portion through most of this. I think I misspoke. And again, that physical length is why there are fewer urinary tract infections. Female urethra, mucosa and muscularis, okay? Much shorter, right? Which is why it's literally a smaller, shorter physical distance for bacteria to crawl into, okay? And you see the external sphincter here, skeletal muscle, and then the internal sphincter is this smooth muscle at the base of the trigger right where the urethral orifice is at the bladder. So again, if you're talking physical distances, bacteria don't typically make it that far. If they do, we have to search for sort of a reason why that happened versus this distance right here, okay? Any questions so far? Simple anatomy, right? Micturition reflex, parasympathetic portion is initial, that urge to urinate where the bladder starts to move the urine down by the internal urethral sphincter, okay? So you start to feel that micturition reflex. I have to go to the bathroom, essentially is what I'm saying. That's what you feel, okay? But you can hold it, right? Typically, you can hold it. This is why this is potty training. Kids learning to contract and hold at that external urethral sphincter. Right? Initially, they have poor control over that. As they get older, as they learn how to control it, that is what creates urinary continence, true urinary continence, potty training, if you will. Okay? And then this should be a low pressure system, right? Urine should just sort of flow out. If it's not, then we might have prostate problems or some other kind of blockage. Okay. All right, and this is about potty training that I just talked about, right? Just takes some practice. I left this in for my friend Terry. She thought this was funny, so hopefully you think it's funny. Not everybody. Why does asparagus make your pee smell? Because you make asparagusic acid. Not everybody actually makes it, so it doesn't happen to everybody. But it's actually called asparagusic acid, which is why it smells that way. Okay? So apparently not funny. Tell her it wasn't funny. Okay. Wasn't funny at all. I didn't think it was funny. All right. Aging in the urinary system. What do you think happens as we age for the urinary system, in the renal system? Huh? What do you think happens to kidney function? It goes down. Kidney size also decreases. You lose functional nephron mass. Chronic kidney disease is on a line from 1 to 100. It happens. The older you live, the worse it gets. Now, everybody will not necessarily experience symptoms, but you will lose functional nephron mass. You will have a decline in your GFR. You will have an experience of an increase in your BUN and creatinine. So your kidney function declines just based on age. Things that accelerate that: diabetes, hypertension, cardiovascular disease, so on and so forth. Okay? So kidney shrinkage, renal blood flow decreases. I know we haven't talked about renal blood flow yet, but the title implies what it is: blood flow to the kidney, right? Which is it's separate, but not entirely distinct from glomerular filtration rate, which also does decline. All right. And then typically, as you age, you're more dehydrated. You typically live in a more dehydrated state, even if you are drinking water. So more prone to kidney stones, more prone to kidney infections and bladder infections, especially in a population that becomes less and less mobile as you get older. Okay, BPH, which is benign prostatic hyperplasia, can lead to the symptoms I've talked about: difficulty urinating, urinary retention. What does everybody remember? I think I said it here once. What is static fluid anywhere in the body is what? Bad, right? Because it's a swamp. So if you have urinary retention, meaning you can't get all the urine out, means you're holding on to urine. What eventually is probably going to happen? Little buggies start to grow in there, right? So you get to experience higher rates of urinary tract infections. Okay. Polyuria. What does that mean? One second. Going to the bathroom all the time. Okay? Going to the bathroom all the time. What is nocturia? Getting up at night to go to the bathroom. And just as a preview to your GU class, this is usually what brings your patients in, right? People can deal with going pee all the time. It's annoying, but it's irritating, but it's livable. When patients have to get up 2, 3, 4, 5 times a night to piss and they are not sleeping and they're grumpy, that's when they come see you, right? I can't sleep. I'm pissing all the time. That's usually what BPH presents at, in my opinion, in my experience, I should say. All right? That is it for today. Okay? Do you guys have any questions about what we covered? Fairly straightforward, simple anatomy stuff, right? Nothing, not rocket surgery. Okay? You have any questions? All right. Happy studying. I will see you guys tomorrow. I'll be here proctoring the exam.
Okay.